Good afternoon, everyone. Thank you for the opportunity. I shall be speaking on grape of the eye, pluck it or preserve it. We had a 31-year-old lady who came in with blurring of vision in the left eye since 3 weeks. There was no metamorphopsia, no history of floaters or flashes, history of multiple prior ophthalmic consultations on which she was diagnosed to have a left eye retinochoroidal mass but had no prior intervention. We had 4 arms basically, which involved clinical examination, an ultrasound biomicroscopy, a B scan, and a systemic evaluation, which was negative for metastasis. Clinically, there was no regional lymph node extension. This is a slit lamp photograph which shows a well circumscribed mass extending from 8 o'clock to 12:30 position, which is pigmented, which was negative for transillumination. But we might be thinking in terms of a benign lesion here at the initial presentation. But to show you next, please have a look at the dilated episcleral vessel and a small focus of an extraocular extension. Gonioscopy confirmed our findings of an angle invasion. Ultrasound biomicroscopy, at the baseline, we measured for the height, width, and also the base of the lesion. At this point, we are dealing probably with an intraocular malignancy, and the flip sides of the coin to manage this would be conventionally to go ahead with the enucleation, where we have the other option being a plaque brachytherapy. But what were the challenges we had? We had an angle invasion, a peripheral iris invasion, and an extraocular extension in the form of a transcleral spread. So we went ahead with a customized plaque brachytherapy in consultation with the radio-oncologist, where the dosimetry for the lesions are decided based on our measurements. And you can see a 2-month follow-up. If I were to just go back to the previous slide, where we have this as a lesion at the initial presentation to what is seen 2 months later following a plaque brachytherapy, is a significant reduction in the lesion size, which was further followed up 2 years later. I'm really sorry for this photograph because it's a poor quality image following gonioscopy. We had taken this photograph, and sequential UBM measurements also showed a reduction in the size of the lesion. Ciliary body melanoma, it constitutes to about 6% of the uveal melanomas, and the most common presenting symptom would be a blurring of vision, which also should be a take-home point, that a simple blurring of vision in a young individual should not be taken lightly or requires a very, very comprehensive assessment. It is diagnosed late as the lesion remains hidden, and ciliary body tumor has a 2 to 4-fold increased risk of metastasis as compared to other posterior uveal melanomas. So 2 things to look at: where did we start and where are we at now? To start with, we had an intraocular malignancy, difficult to explain to the patient, possibly thinking of eye removal, which again becomes a social stigma. And third, most importantly, the systemic spread. Whenever dealing with an ocular malignancy, think in terms of life salvage first, second ocular salvage, and last the vision. Now, we have a patient whose vision was salvaged, globe was salvaged, and there was no metastasis. Thank you.
Do you consider keeping a possibility of ciliary body melanocytoma?
Yes, sir.
Yeah, like as Sir mentioned about retinoblastoma biopsy, was a biopsy done here to prove it?
No biopsy.
Okay. Yeah.
Clinical diagnosis, on the basis of the clinical diagnosis, you have started a plaque brachytherapy. Right?
Yes, ma'am. Clinical yes, ma'am.
But when we talk about melanoma, like you have yourself mentioned that the life is first, then the globe and the site, right?
Yes,
have you
ma'am.
done any systemic workup,
Yes, ma'am.
any PET scan?
Yes, ma'am. We did a whole body PET CT scan, which is negative for metastasis, ma'am.
I saw the regression pattern. It was something like a collapsed, we see the peripheral iris cyst kind of a thing.
Yes, ma'am.
The thing which is like hanging there, yeah.
Yes, ma'am. Peripheral iris pigment epithelial cyst, yes, I would think of. if I was not seeing a sentinel vessel and I was not thinking a transcleral spread. But typically, if you were to look at that lesion, which is well circumscribed above the horizontal meridian, initially my impression would have been a IPE cyst, ma'am.
Right.
And there's
when it
transillumination
collapsed,
negative.
after the treatment.
Yes, ma'am.
Right, yeah.
UVM is a very good test in such cases. UVM is the crucial, very crucial UVM.
It's from a ripe grape to a shrunken one, ma'am.
Sorry?
It's from a ripe grape to a shrunken one.
Yes.
And didn't pluck it yet.
All right. Any more questions from the panelists? Any discussion?
As you have described, blurring of vision
Yes.
is one of the important early symptom.
Yes.
What are the early signs that one can suspect that you may be dealing with a case of ciliary body melanoma?
So, comprehensive clinical science per se is only on a clinical assessment. Now, for example, if I were to deal with ciliary body melanoma, usually remains hidden. But if I'm looking at the anterior segment, say,
Any pupillary sign?
Yes, sir.
Absence of pupillary.
I'm coming to it. If you were to look at the anterior segment examination, and if I'm able to see a neovascularization of the iris, if there is any chorectopia and any heterochromia, and presence of any nevi on the iris and all that, I am thinking in terms of a marker which can progress towards my thought in terms of a malignancy. And also look at the anterior chamber depth. In certain advanced ciliary body melanomas, there can be angle breakthrough or anterior chamber breakthrough or iris extension as well. So if on slit lamp examination, if the AC is of the anterior chamber, is of not a uniform depth, then I would be if there is a fullness in one particular quadrant, go ahead with gonioscopy, look at the angle structures, possible invasion, non-visualization of the angle structures in those terms, sir.
That's good. Thank you.
Thank you.
Excellent presentation.
Ma'am.
So till now we don't have a conclusive diagnosis. It can be a melanoma or it can be a melanocytoma. Or do you feel that no, it is a melanoma, not a melanocytoma?
Not definitely that I would pin it down only to a melanoma, ma'am. I would also consider the differential for a melanocytoma, ma'am.
Supposing it is a melanocytoma,
Ma'am.
do you still prefer a GRAPE?
Weighing the pros and cons, yes, ma'am. If
Yes, in a melanocytoma.
not in a melanocytoma, if I definitely know it is a melanocytoma, no, ma'am.
So in that case, do you suggest that we need to have a pre-treatment any diagnosis?
I would go for a biopsy. Actually, I would go for a biopsy. I have described a case of melanocytoma of the ciliary body in long back in survey of ophthalmology, which has got a prolapse of uveal tissue prolapse. And that was debated quite a long time, and we didn't have that much invasive modality of it's an imaging modality. It's a long back.
So is there any very characteristic feature where you can differentiate melanoma from melanocytoma in UBM?
UVM, I am not sure.
All right, yeah.
In that case, you suggested we should do an FNAC.
Yeah, basically melanocytoma, again there are dense pigment, melanoma doesn't have dense pigment.
Yes,
So sometimes you'll have that in the angle whenever there is a melanocytoma in the ciliary body or the iris, you have dense pigmentation in the angle. So that is one clue that you can always look for. Even thinning can happen in melanocytoma also because if it grows progressively.